So I've been asked to deliver a talk on adjustment of basal insulin. Does it matter? So to start off with, I have no disclosure pertaining to this talk. An overview of my talk, I will go through a very brief introduction, a case study to understand a bit what happens during fasting, go through a very short through about risk of fasting because it's got important implications in terms of treatment adjustment, and go through a few studies looking at evidence in terms of insulin adjustment, and conclude with a few take-home messages. So just to give an introduction, we all understand that fasting represents one of the 5 pillars of Islam, and Brunei being a Islamic country is something that's very widely practiced in our patients, and all adult healthy individual of puberty of age are required to fast. From evidence from epidemiological studies, we know there's a rising prevalence of fasting among patients during Ramadan. The landmark study of the epidemiological study that was done in 2001 showed that 42.8% of patients do fast for more than 15 days. And recently in 2020, there was the Dar International study looking at the Middle East and North African countries from type 1 diabetes, showed a higher prevalence of 72.3% of Muslims with type 1 diabetes who are actually fasting. And last year, with the Diabetes in Ramadan Global Survey, for which there was a publication last year, or they showed that 71.1% actually fasted during Ramadan. However, most guidelines would re-stratify type 1 diabetes mellitus patients as high risk or even very high risk, depending on which guidelines you look at. And but we do know from clinical practice and our daily work that patients still insist on fasting despite advice not to fast. So it's very important as a healthcare provider that we provide patients the necessary guidance to actually fast safely, for which it includes treatment adjustments, and that includes insulin. So this brings me to the next slide of a case study. This is actually a patient of mine, which I just saw not so long ago, actually, it's quite recent in clinic. He's actually Mr. AJ. He's a 18-year-old student. He's got type 1 diabetes for the last 14 years. And that's his treatment regimen. He's on insulin aspart, 8 units at breakfast, 12 units at lunch, 10 units at dinner, and injects insulin glargine U100 at around 30 units in the evening. So he came for clinical review, and he actually expressed his interest to fast because Ramadan is not too far, it's a few months down the line. And currently he's not doing very much, he's waiting for his exam results. He doesn't monitor his glucose very much, which is very common here in Brunei, and I think that's been clearly shown by Dr. Alice in her data that she presented yesterday. In terms of hypoglycemia, he had about 1 to 2 episodes of hypoglycemia per month, but no recent admissions for diabetic ketoacidosis or severe hypoglycemia. And on asking about how did he fast for the last year during Ramadan, and he managed to complete about 15 days, he said, on recollection. And the main reason why he actually had to break fast was due to episodes of hypoglycemia, which happens more towards the afternoon and towards iftar period itself when they break fast. His investigation showed an HbA1c of 8.1% or IFCC HbA1c of 65. His fasting blood glucose was 6.9 millimoles per liter. And his urine albumin creatinine ratio was normal at 0.6, and he had a normal renal function of a calculated eGFR of 122 on his recent blood test. So, do we need to adjust basal insulin dose? And the question is yes or no. And to answer that, it's quite important that we understand what happens during fasting as well. And I think this is something that most of us will be aware, all of us will be aware of when patients do fast for Ramadan itself. They refrain from taking any food or drinking any fluids from morning or during suhoor or dawn, and they will break the fast at iftar when the sun sets itself. And normally they will break fast just like anywhere else in the world. Patients tend to break fast with things that are a bit high in sweet and savory, with a bit of high carbohydrate and fat content from the point. And fasting also varies across the world. I mean, the number of hours you fast depends on where you live. And this was a map that I actually caught from the Al Jazeera website, actually, and it beautifully illustrates how the various time duration of fasting is, depends on where you are along the latitudes itself. The further north, as we all know, the hours are a bit longer, therefore you need to fast much shorter. For me in Brunei, we are in the purple area. So the last year, in 2021, it was about 13, 14 hours, while individuals in the Middle East and Saudi Arabia itself was 14, 15 hours, while in London, it could go all the way up to 16 to 17 hours of fasting for last year for Ramadan in 2021. So do we have any evidence in terms of data, in terms of glucose monitoring that happens during Ramadan itself? Because this is very important information that we need to help us guide in terms of what we're going to do for the patient itself. This chart, I think it's been numerously shared by other speakers as well, by Dr. Nathan, who gave a wonderful talk just now. And if you look at the y-axis, it looks at the mean interstitial glucose, and the x-axis is the time itself, while the blue lines represents the non-fasting, while the red lines represents the CGMS during fasting itself. So what was very striking in terms of the data that was being produced from this CGMS study was that individuals' CGMS tend to go up pre-sahur itself. And what happens is that it tends to slowly go down, and it tends to go a bit towards near the normal, around 6 to 7 from that point of view, and towards the sahur period, sungkai period, iftar period itself. And that's when they will break fast and they will eat, which would lead to the rise in the blood sugars, which is clearly demonstrated here by a glucose excursion that goes up for a few hours after iftar itself. So from this, we know that blood sugars does vary in terms of the variability and excursions itself, based on CGMS studies, which has been reproduced in others as well. So why is it that hinders, or what we're concerned with when patients want to fast, especially among those with type 1 diabetes? We all know there's a risk of hypoglycemia. The PDR study had shown clearly there was a 7.5-fold individuals with type 1 diabetes are developing hypoglycemia. Of course, if we were to adjust we were to reduce the insulin, there's a concern that there may be more hypoglycemia that may develop. And because of the increase of ketogenesis itself during fasting itself, there's also possibly an increased risk of diabetic ketoacidosis, which can lead to hospitalization in patients. And last but not least, is something that's not been really well looked into. I think in terms of dehydration, because of the patients are not drinking as much fluid during the fasting period, and because some areas such as in Brunei, in the hot tropical wet weather, patients may lose more fluid compared to people who live in the cooler weather itself. And lastly, with kids, they are actually more active and physically active, so they do have a higher tendency to get more dehydrated as well in the pediatric population. And last but not least, of course, hypoglycemia itself can also lead to more osmotic diuresis, which can lead to more dehydration. So to talk about these complications, I actually brought this table up, which is from the Dar Global Survey by Dr. Hassanain, and brought in 3 parameters that we are interested in terms of hypoglycemia, and severe events leading to hospitalizations. So if you look at it from the hypoglycemia perspective, about 40% reported no symptoms of hypoglycemia. For about half of this reported in the first week of fasting itself. In terms of hyperglycemia, about 50%, about half, 55.2%, reported no episodes of hypoglycemia, and slightly above a quarter had hypoglycemia over the first 7 days. But much more reassuring in terms of the data that's come up from the Dar Global Survey is that 93% did not require emergency room attendance or hospital admissions for hypoglycemia or hyperglycemia, and less than 7% required emergency room or hospital admissions for hypoglycemia or hyperglycemia. So this, in a way, indicates that if we were to select our patients and stratify them properly, educate them, then we can get our patients to fast safely, provided they get the proper support. So is there any evidence in terms of studies that have been looked into? So I had to go through a bit of literature search to look into this, into basal insulin dose adjustment among type 1 diabetes. And I brought these 3 papers, which are quite well cited as well. And the first one is by Kasim et al., which was done in the pediatric population, about 17 individuals for 30 days. And they looked at the more traditional old human insulin of Ultralante and regular insulin. And what they actually concluded from the study was that patients should be considered to switch to longer acting basal insulin, such as the analogs itself. And they needed there was a dose reduction of about 13% compared to patients who did not fast. So it was a significant dose reduction of 13% of p-value of less than 0.001. Secondly, there's a paper by Al-Khawari looking at 28 individuals. It was a prospective observational study over 30 days, and they looked at conventional pre-mixed twice daily insulin versus multi-dose insulin with insulin glargine as a basal and insulin aspart as your rapid-acting insulin component. And they actually showed that the patients who were on a multi-dose insulin had a higher incidence of hypoglycemia, okay? And therefore, they suggested that patients need to have a dose reduction of about 10 to 20% to help to reduce their risk of hypoglycemia developing while they fast. Last, I would like to bring this paper by Al-Awan, small study looking at 12 patients as a prospective case control over 30 days. And they looked at multi-dose insulin or basal bolus. And this patient actually had a dose reduction of about 20% as part of their treatment adjustment. And it actually showed that patients can actually fast much more safer with such a dose reduction itself in the outcome itself. So looking at these 3 studies itself, they all do advocate for dose reductions. Bear in mind, there are more newer studies that's been published recently, but there's a bit of a mixed group of patients who are on pump therapy, which I'm not going to be dwelling on, that actually may not need dose adjustment as compared to the MDI population itself. But I think proper patient selections, patient educations are important, and I can't emphasize that enough. So just to give you a more recent paper that's been published is the Dar Type 1 Diabetes Survey that was published in 2020. And this was also a very interesting paper that looked at the fasting practices among type 1 diabetes during Ramadan itself. And what I will try to explain in terms of 2 horizontal bar charts here. The A actually shows any change of treatment. So this could be any change of treatment in terms of the type of treatment and medications. And B would be the change in terms of insulin doses itself, okay? So you can see from the bar charts itself, about 84% of patients needed some form of change in terms of insulin, whether it's from one type to another or whether it's a treatment change completely. Interestingly, also, 72% of patients needed a dose adjustment in terms of their insulin during Ramadan from that point. So this will actually add more weightage in terms that, we do need to modify our patients' treatment, particularly in insulin, to reduce the risk of hypoglycemia so they could safely fast for 30 days. So that brings me back to the case study that I just brought at the beginning of my talk. I did the Dar risk score, which is a very useful tool to utilize, and he scored 8.5, not surprisingly, as a high-risk individual. He was counseled that he was high risk for fasting. However, he still wanted to try to fast for this year's 2022 Ramadan itself. So I sort of re-emphasized that he needs to start monitoring his sugars much more frequently in order to fast safely. Of course, pre-Ramadan education, which will be arranged nearer to time. And in this particular case, I actually advised him to reduce his glargine dose by about 10%. So he went down from 30 units of glargine. So I actually asked him to go down to around 26 units of glargine instead. Partly because if you remember, because with his past year's history of fasting Ramadan, he tended to have a hypoglycemia towards the mid-afternoon towards mid-afternoon and iftar period. So hopefully by reducing the glargine dose itself, it might help to prevent him from getting the hypoglycemia. Something that I do as my regular practice is that I tend to advise patients to try to attempt fasting about 1 or 2 weeks prior to the holy month itself, so that they don't, if they do fast, hopefully they have a better chance of successfully fasting for the full 30 days and rather than having to break the fast during that period itself. And of course, not to mention, I actually would actually provide teleconsultation, something that we started using quite a lot, especially in the COVID pandemic, and something to provide support and to kind of get feedback in terms of how he's doing in terms of his fasting, even during his trial period prior to the Ramadan month itself. So that comes to my last slide in terms of the conclusion, take-home messages that I would like to convey. Hopefully, with what I presented, it's quite clear that evidence do support that a 10 to 30% reduction in basal insulin is actually advisable in most patients with type 1 diabetes. But I cannot emphasize this enough that, I mean, just like any management of diabetes or chronic disease, we need to individualize our management itself. One size really does not fit all. And your personal experience and patient experience is very important in terms of creating a proper management plan for the patient. Last but not least would be to re-stratify the patient and to provide proper structured pre-Ramadan education, which has clearly been shown through evidence and literature to help patients fast safely through Ramadan itself. I would like to end this talk that I've given today with a picture of people of Brunei with the wonderful SOAS mosque in our background, looking all in different directions. And what I'm trying to say is that hopefully with more education and more reinforcement of using the risk stratification, we can hopefully have all these individuals look in the same direction and be able to fast in a more safe month for the upcoming Ramadan in 2022. With that, I thank you for your attention, and I'll leave it to the question and answers towards the end. Thank you very much.